This is the first time ever to have a session of the MR imaging of the pelvic floor in general with ultrasound and MRI. And afterward, we have a very nice and very practical workshop. First time to be done in Egypt is the ultrasound of the pelvic floor conducted by Dr. Ola from UK. So you are invited to come afterward. We will start our session with Professor Heba from Cairo University. She's with us in the unit of MR imaging of the pelvic floor. She's going to give us a talk about basics of pelvic floor anatomy and imaging. Shukran.
Thank you, Dr. Rania, for the nice introduction. What is pelvic floor dysfunction? Pelvic floor dysfunction affects 1 in each 4 women. It can present with urinary incontinence, pelvic organ prolapse, fecal incontinence, obstructive defecation, sexual problems, or even chronic pelvic pain. Proper interpretation of MR findings associated with pelvic floor dysfunction is of utmost importance in order to do proper surgical planning, thus reducing the rate of reoperation, which is very high in pelvic floor cases, reaching 30% of the cases. What is the pelvic floor made of? It's made of muscles, fascia, and fibrous tissue that intermingle together to support the pelvic organs. The first layer we're going to talk about is the endopelvic fascia. The endopelvic fascia is a continuous layer of connective tissue that connects and attaches the uterus and vagina to the pelvic bone, therefore supporting pelvic organs and preventing genital organ prolapse. As we can see here, it's the most superior layer of the pelvic floor. This one, the green one. Sorry. Beneath it is the levator inni muscle, and the last layer is the urogenital diaphragm. However, though the ligaments and perineal body are the only components of the endopelvic fascia and ligaments that are directly seen on MRI images obtained with the standard sequences, yet, though it's not directly imaged, its failure in organ support can be interpreted on MR imaging. We can see the fascia, but we can see the effect of its failure. Endopelvic fascia can be classified in many ways, either anatomically, the part forming the anterior support, which is the pubocervical fascia, this white sheet we see here, extending between the uterus and the pubic bone, and posteriorly, the rectovaginal fascia, this one here, between the uterus and the rectum. And the middle part is the parametrium and paracolpium, attaching the uterus and vagina to the side pelvic walls. However, there is other classification that helps us in detecting the level of fascial defect we see on MRI. It's classified by Delancey. The fascia is classified into 3 levels. Level 1 is called the level of suspension, in which we refer to the upper portion of the vagina, which is suspended by the uterosacral and cardinal ligaments from the lateral pelvic wall. And the defect in this level is seen as posterior sagging of the vagina bilaterally due to detachment from the uterosacral ligaments, causing this appearance, which is called chevron sign. Level 2 is called the level of the attachment, which is the mid portion of the vagina. This is level 2, in which the vagina is attached to the arcus tendinous fascial complex. And the defect causes sagging of the posterior urinary bladder wall due to loss of the vaginal supporting fascia from the lateral pelvic wall. Usually, it's posterolateral, like this. Sometimes there is a central defect indicated by sagging of the central part of the urinary bladder. This sign is called saddleback sign. Level 3 is the level of fusion. It refers to the lowermost part of the vagina, in which the vagina is fused anteriorly to the urethra, posteriorly to the perineal body, and laterally to the levator inni muscle. Failure in this level causes bilateral sagging of the fat in the prevesical space against the detached lower third of the vagina. Here, as we can see it, it's called the drooping mustache sign, and the fat sagging here resembles the mustache. So we can see the fascia, yet we can see the defect in each level. The perineal body, it's a pyramidal-shaped muscular fibrous structure situated between the vagina and the anus. It's also called the central tendon of the perineum because it receives attachment from the puborectalis muscle, perineal muscle, anal sphincter. The muscle support. We have three major groups of muscle. The levator ani and coccygeus muscle forming the pelvic diaphragm, the obturator internus and piriformis muscle, and the external genital muscles. However, the only muscle that has active role in the support of the pelvic floor is the levator ani muscle. The other muscles doesn't have an active role. As we can see here, this purple triangular muscle is the piriformis muscle. We can see it here. Anteriorly, this orange muscle is the obturator internus muscle. We can see it here. The blue triangular shaped muscle here is the ischiococcygeus muscle, as we can see it here. And the green muscle is the levator ani muscle, which is composed of three parts: the puborectalis, the pubovisceralis, and the iliococcygeus muscle. The posterior fibers of the levator ani muscle fuse together, forming the levator plate. Here, this is the puborectalis pubovisceralis complex, and posterior, this triangle is the iliococcygeus muscle. As we can see here, this is the iliococcygeus muscle, and this is the puborectalis pubovisceralis complex, and this is the levator plate. The puborectalis muscle arises from the pubic bone, forming a U-shaped string behind the rectum that is responsible for the formation of the anorectal angle. The space between the two limbs of the puborectalis muscle, through which the urethra, vagina, and rectum passes, is called the urogenital hiatus. The puborectalis can be seen, or is best seen, on the axial MR images. We see it in more than one plane, so we can assess the thickness of the muscle, either there is a defect or not, or it's normal. It can be also appreciated on the sagittal images, just posterior to the anorectal angle, and the coronal images beneath the iliococcygeus muscle. Here we see this muscle bulge, seen bilaterally, is the puborectalis muscle. It's seen between the iliococcygeus muscle and the anal sphincter. The second part of the puborectalis of the levator ani muscle is the pubovisceralis muscle. The pubovisceralis muscle also arises from the pubic bone. It's divided into more than one partition: the pubourethralis, the pubovaginalis, and the analis, pupoperinealis. Yet we cannot differentiate these partitions at the site of origin. We can differentiate it only by its insertion. Here we can see the puboanalis, which is inserted into intersphincteric space, the pubovaginalis inserted into the right vaginal wall, and the pupoperinealis inserted into the perineal bodies. On the coronal images, we cannot differentiate the fibers of the pubovisceralis muscle from the puborectalis. The third part of the levator ani muscle is the iliococcygeus muscle, which arises from the arcus tendinous fascia covering the obturator internus muscle. Here's the obturator internus muscle, and this is the origin of the iliococcygeus muscle. We can see it here in the coronal images. The iliococcygeus muscle is best appreciated in the coronal images. So we can see it here bilaterally. This is the left iliococcygeus, and this is the right iliococcygeus muscle. In the axial images, we can see fibers of the iliococcygeus muscle. The space between the levator ani musculatures through which the urethra, vagina, and rectum passes is called the urogenital hiatus. The fusion of the levator ani where they meet in the midline creates is the so-called levator plate, as we said before. Okay? So the anterior portion of the levator ani complex serves to close the urogenital hiatus and pull the urethra, vagina, perineum, and anorectum toward the pubic bone, where the horizontally oriented posterior portion, the levator plate, serves as a supportive diaphragm or backstop behind the pelvic viscera. With consequent weakening of the muscle, there is widening of the hiatus and sagging of the levator plate, as we can see here. With more weakness, there is more widening and more sagging. The urogenital diaphragm is the lowermost layer of the pelvic floor. It's the hypointense structure we're seeing here, pointed by the white arrow. It covers the anterior portion of the urogenital hiatus and aids in the continence mechanism of the urethra. The urethral ligaments. We have the ventral urethral ligaments, which are pubourethral ligament, periurethral ligament, and paraurethral ligament. The pubourethral ligaments are linear, broad structures on either side of the midline. We can see him here in the axial, this one and this one. And in the sagittal, we can see it at this line as it extends from the pubic bone to the bladder neck. The periurethral ligament is a transversely oriented ligament anterior to the urethra at the level of the urethrovesical junction, as we can see it here by the black arrows, this one. And the paraurethral ligament is an obliquely oriented ligament that extends from the middle of the urethra to be inserted in the periurethral ligament here. This is the site of its insertion in the periurethral ligament. So we have three anterior ligaments, the pubourethral, the periurethral, and the paraurethral. We have only one dorsal urethral ligament, which is the suburethral ligament. It's this hypointense structure seen posterior to the urethra. The anal sphincter. The internal sphincter forms the innermost muscular layer and is the terminal condensation of the circular rectal smooth muscles. The external sphincter is the outermost muscle of the distal anal canal. It's circular structure and shorter anteriorly in women, approximately 1.5 centimeter. The external sphincter extends 1 centimeter beyond the internal sphincter. This is a coronal diagram of the sphincter. The external sphincter is divided into 3 parts. The subcutaneous part, this one, as we can see here, the superficial part of the external anal sphincter, and the deep part of the external anal sphincter. This is the internal anal sphincter, and in between them is the intersphincteric space. Above the sphincter here is the puborectalis muscle, and this is the iliococcygeus muscle. This is a coronal oblique image demonstrating the exact same thing we've seen in the diagram. This part is the subcutaneous part of the external anal sphincter. This is the superficial part, and this is the deep part just beneath the puborectalis muscle, and this is the iliococcygeus muscle. Here, this is the intersphincteric space, and this is the internal anal sphincter. In the axial images, we see here, this is the external anal sphincter, this is the intersphincteric space, and this is the external anal sphincter, the intersphincteric space, and the internal anal sphincter. So we can see different parts of the anal sphincter on coronal and axial images. Now we have to know how to interpret an MRI of the pelvic floor. The static MRI provides detailed anatomical information, and the dynamic MRI gives the opportunity to study the function of the pelvic floor organs in the form of mobility and reaction during different physiological and provocative activities. We're going to start with the static MRI. In the axial plane, we can see a lot of stuff. First of all, we can see the urethral ligaments. As we have seen the normal ones, we can assess whether they are normal, there is distortion, or defect. The second thing we can see here is the endopelvic fascia. As we said before, we cannot see the endopelvic fascia directly, yet we can see the effect of the failure of each level. This is level 1 defect, which is called the chevron sign. This is level 2 defect, which is called the saddleback sign. And this is level 3 defect, which is called the drooping mustache sign. We can also assess the puborectalis muscle. As we said before, the axial plane is one of the most important planes for assessing the puborectalis muscle. Whether there is a defect, this is unilateral defect in the right puborectalis muscle, or bilateral, as we can see here. There is detachment of the puborectalis muscle from the pubic bone, and there is defect here in the puborectalis muscle. Usually, unilateral defects are much easier to detect as they are compared to the normal side. We can assess the anal sphincter in the axial plane, as well as the vaginal configuration, which, as we can see here, is H-shaped or butterfly shape, and it's distorted if there is fascial defects. In the coronal plane, we can assess the anal sphincter complex, as we explained before, and the iliococcygeus muscle. In the sagittal plane, we can assess the perineal body, here, situated between the vagina and anus, and the levator plate, which is the posterior part of the levator ani muscle. In the dynamic MRI of the pelvic floor, in the sagittal plane, we use the pubococcygeal line as a reference line. It's the line extending from the inferior border of the symphysis pubis to the tip of the coccyx posteriorly. And then we detect the relation of the bladder base, uterus, and anorectal junction to the pubococcygeal line during rest and during straining to assess the degree of descent of the organs with straining and evacuation. Here, this is the pubococcygeal line. This is the relation of the organs during rest. And here, you see the marked descent. This is a case of pelvic floor dysfunction, definitely. In the sagittal plane, as we said, we can assess the vertical distance to the pubococcygeal line. We can also assess the H line, which is a line extending from the inferior border of the symphysis pubis to the posterior anorectal junction. This line represents the anteroposterior width of the hiatus. As we can see here, this is the H line. We can assess the M line, which is a perpendicular line between the M line and the H line and the pubococcygeal line. Here, this is the M line, which represents the degree of descent of the pelvic organs. We can also assess the levator plate in the sagittal plane. It's the angle levator plate angle, sorry. It's the angle enclosed between the pubococcygeal line and the line of the levator plate. Normally, it should be 11 degrees plus or minus 5 degrees. However, in cases of pelvic floor dysfunction, it increases. Okay. Also in the sagittal plane, we can assess the anorectal angle, which during rest should be between 90 and 120 degrees. During straining, it becomes more acute, and during defecation, it becomes more obtuse, allowing the defecation. In the axial plane, we assess the width of the levator hiatus during rest and straining. In cases of pelvic floor dysfunction, there is ballooning of the hiatus. And in the coronal plane, we assess the iliococcygeal angle, which is angle measured using an imaginary line between the points of origin of the iliococcygeus muscle on both sides, this line, connecting the origin of the iliococcygeus muscle, and the other line goes with the line of the muscle itself, normally at 33 degrees. So we have 5 measurements to assess the condition of the muscle: the H line, the M line, the levator plate angle, the width of the hiatus, and the iliococcygeus angle. We combine the finding from the static images and the dynamic images to see if there is specific anatomical defect causing certain functional abnormality. Thank you so much.
It's not working. Okay. Thank you, Dr. Heba, for your very informative lectures and giving the basics of